second discussant, Dr. Maryam Lustberg from Yale University School of Medicine. And we do have three abstracts that will be presented, and one of those presenters, Dr. O'Donnell, is here in person, so she'll come up and join us for the question and answer. The other two presenters will be with us virtually for the question and answer. Thank you, Dr. Lustberg.
Thank you so much for joining. And I have the pleasure of presenting three wonderful abstracts to you on fertility and breast cancer survivorship, and a third abstract on fasting. And I promise they will all fit together. So the three abstracts that I will be presenting, the first two go together. Abstract 1778, which evaluates the safety of assisted reproductive technologies before and after anti-cancer treatment in young women with breast cancer. Abstract 848 specifically focuses on the safety of assisted reproductive technologies in young women with germline BRCA1 or 2 alterations having a pregnancy after breast cancer. And the third abstract is a pilot study to assess prolonged overnight fasting in breast cancer survivors in the long fast study. And the first two authors will be present virtually. The third author, Dr. O'Donnell, is here in the panel with me. So starting with the first two abstracts, we have a wealth of evidence and published guidelines reinforcing that fertility preservation is crucial and important aspect of cancer survivorship care in patients with cancer who are in reproductive ages. Here you see guidelines from both ASCO and ESMO emphasizing the importance of discussing fertility preservation to patients so that they know all their options. Just a quick aside that in 2021, we also had an update that ovarian tissue cryopreservation was also considered a standard therapy for fertility preservation, in addition to the more well-known or well-practiced controlled ovarian stimulation for oocyte and embryo cryopreservation, which is considered a standard of care for young women with breast cancer wishing to preserve fertility. We have dozens of studies establishing the safety of these methods, although less published evidence on assistive reproductive technologies in breast cancer survivors after completion of anti-cancer treatment. And many patients and oncologists worry about the safety of assisted reproductive technologies in young women affected by breast cancer, particularly those patients who have hormone-sensitive tumors. And this has been one of the many barriers faced by patients in terms of being referred to oncofertility consultations and having this option discussed with them. And similarly, there is some limited evidence in the BRCA1 and 2 alterations, patients with these alterations. We do have evidence that they may be more vulnerable to the effects of cytotoxic chemotherapy on their ovarian reserve. So part of the wonderful work of the two research groups whose abstracts I'll summarize is that they are synthesizing and summarizing the safety data of both controlled ovarian stimulation and assisted reproductive technology by pulling together all the available data that we have in the literature. And this point we'll come back to, which is that in addition to safety data, barriers have included implementation of oncofertility, and these barriers have included awareness, access, and financial constraints. So the two abstracts that are complementary by Drs. Orecko and Condorelli with senior author Dr. Matteo Lambertini, I will discuss them together, abstracts 848 and abstract 1778. So starting with Condorelli et al. In abstract 1778, this was a systematic review with no date restriction up to June 30th, 2021. They included case control or cohort studies that compared survival outcomes of women who underwent controlled ovarian stimulation or assisted reproductive technology before and after breast cancer treatments, compared to breast cancer patients not exposed to these strategies. Here you see the diagram of the studies included, including 15 studies with over 4,000 patients, 11 studies reported outcomes of patients who underwent controlled ovarian stimulation, and 4 studies reported outcomes of survivors who underwent assisted reproductive technologies. And by assisted reproductive technology, we're talking about in vitro fertilization, embryo transfer, and other measures to help achieve a successful pregnancy. Reasons for exclusion of studies included overlapping populations, absence of a control group, small case series, and not having oncologic outcomes. The results were very reassuring. These forest plots describing breast cancer recurrence in patients undergoing ovarian stimulation showed that there was no adverse effects in recurrence rates in breast cancer. Similarly, focusing on the patient population with hormone receptor positive disease, again, use of ovarian stimulation was not associated with worse disease outcomes. In terms of the assisted reproductive technologies, again, we see no adverse effect in recurrence in survivors. So all reassuring data, again, emphasizing that oncofertility is a standard of care and should be discussed with every patient. In terms of what effect these measures did have, they did delay this initiation or time to start of systemic chemotherapy by about 6 days. However, this was not associated with worse outcomes. So then going on to the second abstract, this abstract specifically focused on outcomes of a cohort of BRCA, patients with BRCA mutated breast cancer who had a pregnancy after a history of breast cancer, comparing the population of patients who underwent ART to those that became pregnant naturally. The analysis was conducted on a previously published retrospective international multi-center study, and the inclusion criteria are listed here. These were younger women with early stage breast cancer with known BRCA1 or 2 alterations. I have the cohort under investigation here as a reference for you. This was published in the Journal of Clinical Oncology by Lambertini and team in 2021. And the results of that published study showed that looking at the cohort together, patients with BRCA alterations were able to have successful pregnancies that did not impact their disease outcomes, and they had also favorable fetal outcomes. So in this particular abstract submitted to this meeting, the group focused specifically on patients who had been exposed to assisted reproductive technologies to achieve the pregnancy. That was the ART group, small numbers of 22, and compared them to women that were able to achieve the pregnancy naturally without the use of ART, and that was 146. Generally, the ART group tended to be slightly older with a median age of 33 compared to 30 otherwise, and they tended to be more likely to be nulliparous at the time of trying a pregnancy. Otherwise, many of the other clinical demographic features were very similar between the two groups. In terms of reproductive outcomes, they were very similar across both groups. You can see the type of assisted reproductive technologies that were attempted, and these included embryo transfer under hormone replacement therapy, use of an oocyte donation in certain patients, and other IVF technologies. Generally, the median time to pregnancy was a little bit longer in the patients in the ART group, and they tended to be a little older at the time of achieving pregnancy, which all makes sense in terms of needing to use those technologies. Otherwise, the pregnancy outcomes were similar between the two groups. In terms of oncologic outcomes, again, we saw no worrisome safety signals in the group undergoing ART group, and in terms of disease-free survival, it was similar to improved in the ART group, which could be a selection bias, but essentially there were no worsening disease-free survival or overall survival or increased death or recurrence between the two groups. The study has been reported in this publication by the group, and I congratulate the team for contributing and synthesizing this data, so we have clear data on patients with BRCA1 and 2 alterations. So concluding the two abstracts, we can say based on synthesis of the available data in the literature as well as the published data in the BRCA1 and 2 patients that controlled ovarian stimulation and assisted reproductive technologies does not seem to worsen the prognosis of young women affected by breast cancer, including those with hormone receptor positive disease. Undergoing controlled ovarian stimulation does delay anti-cancer treatment slightly by about 6 days, but this is not associated with worse outcomes. And ART is safe in patients with a history of breast cancer with BRCA1 and 2 alterations. In summary, these findings further support vetted oncofertility guidelines, which should be further reassuring to all patients and oncologists as they consider their reproductive options. Additional conclusions and future steps related to these two abstracts. Implementation will continue to be a huge issue in terms of how we actually implement these guidelines across multiple sites, community setting, academic sites, and globally. Positive study, which I will present in the next slide. The data are still maturing, and this will be an important contribution as we further understand prospectively the effect of endocrine therapy interruption in women with history of hormone receptor positive breast cancer. Issues of access and disparities continue to be an issue that have to be addressed, including financial toxicity of fertility preservation techniques. And additionally, I do want to highlight that these studies focused on women with non-metastatic breast cancer. And as we have a growing number of patients living with metastatic breast cancer, additional oncofertility research and discussions need to be had in patients living with advanced breast cancer. Just wanted to do a shout out to positive study. Multiple international investigators, including Dr. Partridge and Dr. Ruddy, is also involved with this study. And the initial demographic and baseline data were just recently published. And I think this study will be a really important contribution as we further understand prospectively the effect of pregnancy and endocrine therapy interruption in women with breast cancer. Before I close this first two abstracts, I do want to dedicate this session to my patient, Lindsay Gianoble, who her family has given me permission to share her story here. She was a young woman who was diagnosed with breast cancer in her late 20s. She subsequently progressed to metastatic breast cancer, and more than anything, she wanted to have a child. And we had done oocyte preservation and embryo cryopreservation, and due to her metastatic disease, which was doing well at the time, a surrogate was used, and there's a beautiful boy who's 8 years old now. So it's important that all our patients know their options. Moving on to the third abstract, which is a pilot study to assess prolonged overnight fasting in breast cancer survivors, the Long Fast study. The background to this study is that there is extensive data in rodents that prolonged fasting during the sleep phase may positively improve cancer outcomes in mice. The mechanism may be related to reduced inflammation, improved glycemic control, and other proliferative pathways. A number of retrospective studies have been analyzed, including the NHANES data, which showed that prolonged nighttime fasting was associated with decreased glucose. And another study, which I will present in the next slide, actually showed that that nighttime fasting may be associated with improved breast cancer outcomes. So this was the Well study by Maryam et al., which was published in JAMA Oncology. And data were collected from over 2,000 women with breast cancer, without diabetes, and who had been participating in the Women's Healthy Eating and Living Study. And by recall data, patients were asked how long their nighttime fast was, and it investigated what the duration, whether the duration of nighttime fasting actually predicted recurrence and mortality. The most positive finding of the study was that breast cancer events, at shorter nighttime fasting was associated with increased breast cancer events, and a greater nighttime fasting was associated with better outcomes. There was no significant effect on breast cancer-specific mortality or all-cause mortality in this study, but this was compelling data, retrospectively, that nighttime fasting may positively outcome breast cancer recurrence rates. So in the long fast study, the investigators designed a single-arm pilot study to evaluate the feasibility of fasting for 13 hours overnight for 12 weeks among women with a history of early-stage breast cancer. Baseline and end-of-study assessments included body mass index, quality of life, mood, fatigue, physical activity, and blood biomarkers. The primary aim was feasibility, defined as greater than 60% of participants documenting fasting for 13 hours on at least 70% of nights during the study. Early-stage breast cancer patients who had completed adjuvant or neoadjuvant chemotherapy, radiation, or surgery for at least 6 months prior to registration to the study were considered eligible. You can see the patient characteristics, pretty standard. Median age was in the late 50s. The majority of the patients were either overweight or obese. Mostly a white population. ER positive was the most common subtype, and kind of evenly distributed across stage 1 and 2, with a minority in stage 3. The majority had received some type of IV chemotherapy for their adjuvant or neoadjuvant treatment. What the results showed was that it was feasible for women with these characteristics to fast for greater than 13 hours. Here you see the average hours fasted and the proportion of days that they were able to fast greater than 13 hours. All the measures met the feasibility criteria that I initially presented. As you can see, as time goes on in the study, there was a trend toward lowering of those proportions, but they still fell within the feasibility criteria. In terms of body mass index, there was a modest decrease in body mass index from 26 to 25. However, other measures of glycemic control or lipid profile or anti-inflammatory markers were not significantly different with time across the 12 weeks in this small study, which was a feasibility study. There were positive improvements in depression, anxiety, and fatigue as time progressed, and these are documented here. So caveats and conclusions on this abstract: it is feasible, based on this early study, to implement prolonged overnight fasting post-breast cancer treatment for 12 weeks. There was a modest decrease in BMI and improvement in anxiety, depression, and fatigue, although some of this could be that patients are further along from their initial treatment, and these things may have improved regardless. Unclear what, to me, and our primary author may be able to answer, is what training and support patients actually had for the intervention. I also did not see actual caloric intake being displayed, and I'm not sure if it was tracked. It was a non-randomized study. Understandably, since it was a feasibility study, the diversity of the sample population was low, and the results are interesting, and certainly additional studies are needed based on these feasibility data. I do want to just highlight one published randomized study that was not in the cancer population that was recently published in JAMA Oncology, in JAMA Internal Medicine, which looked at intermittent fasting for 18 hours, not the 13 hours in this study, as a weight loss measure. And in this study, there was no difference in weight loss between the two groups, and they specifically did not control for caloric intake, and basically the two randomized group where a group that ate 3 structured meals and a group that essentially fasted from 8 p.m. to 12 p.m. the following day. Obviously, a completely different study population, but I think important that in terms of weight loss itself, intermittent fasting may not be beneficial, although whether it has positive outcomes on cancer events, that's something that we need to design larger studies to evaluate. So how did these 3 different abstracts come together? I think they all focus on how can we best preserve quality of life and reduce chances of recurrence in a patient-centered way. And the best way I can summarize them is through the cancer survivorship framework, where we see our treatments having certainly physical effects and psychological effects. We're always worried about recurrences and progressions, and we're concerned about health promotion and managing the chronic comorbidities of our patients. So all these studies touch on all these different areas, and studying them and putting them in the context of the survivorship framework is helpful. And I will end by saying that although all these studies focused on early-stage breast cancer, there is a focused movement to also address the survivorship needs of patients with advanced and metastatic cancers, and this is an important area for further study. And this is being supported by both NCI and multiple other organizations. Thank you very much.
Thank you, Dr. Lustberg, for an excellent discussion. We have a few minutes for questions, so I'll encourage you in the room to go to the microphones, and we do have one online already, which is for Dr. O'Donnell, asking about whether the increased length of nighttime fasting was associated with other factors, such as increased length of sleep or other health associations, such as exercise, mindfulness, or other factors that might have impacted health.
So these are really important questions. I think this one is on. Thank you. So these are really important questions, and just to get at some of the questions asked during the presentation. So as with the randomized study that was shown, this was there were no dietary restraints in this. The counseling was done. I saw all 40 patients and performed counseling for each of them and instructions on how to fast, and data was collected through logs. We did survey patients on using the Golden Leisure Time exercise questionnaire. We did not see statistically significant changes in activities. And we did not, unfortunately, record sleep. I think sleep is a really important consideration, in terms of how we eat and the time of eating. That can certainly impact sleep quality. We know that also impacts cortisol levels and glucose control.
Thank you. We'll go to the microphone.
Hi, Dr. Walker, Henry Ford Hospital. So you did answer some of my questions just a minute ago. Since you didn't restrict calories, did you do any instruction on more of a plant-based diet, or did you assess the microbiome?
I wish we had the funding to assess the microbiome. That would be fascinating. No, so, it's great that you highlighted Catherine Marinak's work. She's done a really beautiful job at examining the well data and observed that, as noted, those women who fasted for less than 13 hours per night had an increased risk of breast cancer recurrence. So in full disclosure, I'm a multiple myeloma doctor. I'm also the director of lifestyle medicine at MGH, a clinic I founded in 2016. 85% of the patients I see are breast cancer patients, and 90% of them come to me seeking advice about weight loss, about the impact of their weight on their breast cancer outcomes, and exercise. And so that was a huge factor that influenced why we chose to do the study that we did. Using Dr. Marinak's observation, we thought that was a good starting point for feasible and doable interventions that people could potentially sustain.
And so I was going to say, I know you didn't have a lot of diversity in your patient population. And so, given I'm a medical director of integrative medicine for Henry Ford, so we're right up the same alley. But did you look at it with your patients at all, or looking at their logs, the type of diet they want? That's why I asked about plant-based versus Mediterranean, and looking at indigenous diets that could be healthier.
So I would love to have gathered that. We didn't want our results to be biased and add a layer of diet to it. It would have been nice to collect that information. In terms of the diet that I recommend, though, I certainly recommend a plant-based diet. There are other diets, such as the Mediterranean diet, that have good cardiovascular outcomes that have been well studied and documented, but we did not specifically recommend a diet for the purposes of this study.
Okay, thank you.
Hi there, thank you so much for the wonderful presentations. My question is directed to the authors of the first two abstracts discussing assisted reproductive technology. My question is specifically, when we look at patients who had ART after breast cancer, is there any published data that you saw dividing patients by the trigger shot they received, whether they were primed with progesterone or estrogen? Because anecdotally in the ART world, I've seen pretty significant pushback depending on the trigger that is recommended for patients who have hormone-positive breast cancer. So I think it'd be interesting if there's any data on that.
Drs. Lambertini and Areco?
Thanks a lot for your question. Thanks for the discussion and for letting us connect in online. So this is an important point, and unfortunately, most of these small studies that reported on ART following treatment completion did not actually report precisely on the type of stimulation that has been used. This is something that we need to address and we need to improve. However, something I wanted to stress is that the standard of care in this field is fertility preservation before starting anti-cancer treatment. There we have much more data, as Dr. Areco has shown in his meta-analysis, and also on the type of stimulation, the type of triggering, and the different type of hormonal manipulation that can be made. Following treatment completion, data are much less strong and with a lot of missing information.
Thank you so much.
We'll take one more question.
Good evening, I'm Lindsay Livingston. I am a triple-negative breast cancer survivor and the founder of Survive Her, my nonprofit. Prior to receiving neoadjuvant chemotherapy, I underwent egg preservation or oocyte preservation, after which I proceeded with 15 rounds of chemotherapy, breast bilateral mastectomy, breast reconstruction, and I am a BRCA1 gene mutation carrier. Therefore, I had a salpingo oophorectomy. Do you have, and speaks to the abstract number 2, do you have any data that supports success in pregnancy for women who are without their ovaries and fallopian tubes? I simply just have my uterus.
Thank you very much for this question. Indeed, a very important one. So I don't have data on these specific issues, but this is something that is feasible and is possible to carry a pregnancy even without the ovaries. However, I don't have specific data on a safety perspective in breast cancer survival in this field. We are working on the same study that we have just presented to try to kind of increase the sample size and prolong the follow-up to provide more solid data on these regards, and also to provide more solid answer on the type of ART that has been used in this setting, including among patients that receive risk-reducing surgery. So I hope that in a few years from now we can hopefully address this question more precisely.
Thank you. We'll move on to our final discussant, Dr. Tara Samp from Yale Cancer Center.